Good evening, everyone. We are about to get started. So welcome to Friday Night AI. We are very pleased to virtually have you join us tonight. My name is Rada Mihalcea. I'm a professor of computer science at the University of Michigan. I'm also the director of the Artificial Intelligence Lab. And as we know, these are very challenging times for all of us. We've been witnessing for the past few months one of the largest outbreaks in history. And COVID-19 has affected all of us in many different ways. Of course, as we know, the health of those affected and their care providers in the first place. But the pandemic has also had many other major implications in health, economy, education, and so much more. In the AI lab at Michigan, soon after the lockdown has been instituted around mid-March, we started a series of conversations between researchers in the AI lab and medical doctors and healthcare practitioners. And what we wanted to do with those conversations is to reach an understanding of the challenges that are raised by COVID-19, and also to brainstorm about ways in which we could help with our expertise in AI. Through these virtual meetings that we held, and also through many other research meetings that have happened across University of Michigan and not only, there are several research projects that have started, which leverage both medical knowledge of health professionals as well as technical expertise of AI researchers. So tonight in this Friday Night AI, we want to share with you some of the work that we've been doing in AI for COVID-19. And I'm really happy to be joined here by both medical professionals and AI researchers to talk about the work that they've been doing. Now, before we get started, just a few logistics. This is an event in a series of events that we've been organizing, Friday Night AI. We've been doing this for a little over a year, and they traditionally happen at the Ann Arbor District Library in downtown. This is the first that we are holding virtually, but we'll try to the extent we can to organize it similarly to the previous events. So for the first 40 minutes, I will start by introducing the panelists, and we'll hear from them about the work they've been doing to address challenges related to COVID-19. And then for the second half, you as audience will have the opportunity to ask questions. We ask that you please use the Q&A button that you can see at the bottom of your Zoom screen to ask your questions. You cannot really use the chat, so that's disabled, but you can use the Q&A. All right, so with that, we can get started. And before I introduce the panelists, I want to say again that tonight, Friday Night AI is a collaboration between Michigan AI, Michigan Medicine, and also jointly with the Ann Arbor Public Library, which is broadcasting the event live on YouTube as we speak. So let me start by introducing the panelists, and you should be able to see them. First off, we have several people from the AI lab. So we have Nikola Banovic, who's an assistant professor of computer science and engineering at U of M. And he focuses primarily through his work on creating computational models of human behavior to study and understand human behaviors, and also to enable technology that can automatically reason about people's behavior in order to help them be productive, healthy, and safe. Also from the AI lab, we have Laura Biester, who is a second-year PhD student in computer science. And she works on natural language processing and computational social science. And she's particularly interested in applying natural language processing methods to gain a better understanding of changes in mental health. And then we have Charlie Welch, who's a fifth-year PhD student in computer science. And he works also on natural language processing, and he focuses primarily on dialogue systems and personalization. And he worked on applications of AI to counseling and motivational interviewing. I'm also from the AI lab, and I'm also part of some of the projects that will be presented tonight. And then we have from Michigan Medicine, we have Larry Ann. He is a general internist and associate professor of internal medicine at Michigan. He is also co-director of the University of Michigan Royal Cancer Center for Health Communication Research and the Health Communication Share Resource. He is overseeing a large multidisciplinary group of behavioral scientists, computer programmers, and design experts that have developed over 100 programs for health communication. We have Brahmajee Nallamothu, who's a cardiologist and associate professor of internal medicine at U of M. He practices interventional and critical care cardiology, and his research is focused on population-based studies that incorporate the use of large claims data and clinical registries to understand patterns of cardiovascular care delivery. Along with Larry and several others, he's actively working on AI approaches to health. And we also have Erkin Otles, who's an MD PhD student at U of M, where he works on research on using machine learning to improve health. Over time, he has contributed to several projects in this space. Among others, he worked on development of analytical reports for healthcare quality improvement work, and also on developing tools to process electronic medical records. So with that, before we even delve into how AI can be used to address challenges related to COVID-19, I would like to first start by trying to set a background on what has been happening here at Michigan. We have all of us following the unfolding of COVID-19, mainly through news outlets, but I will ask us to hear firsthand from people who were involved directly with the planning and care here in the Michigan hospitals. So I will ask Brahmajee if you could please give us a brief summary of what was expected at first, and then how Michigan got ready. In general, what has been the course of the outbreak in the Michigan hospitals?
Well, thanks, Rada, and it's a great privilege to be here. I wanted to say a couple things. It's just remarkable when you think of like all the whirlwind of activity that's happened. I mean, the last couple of months has felt like a decade at times in terms of like everything that many of us have been through, and particularly those of us in the healthcare sector. And so I think it's a great question to start off with. You know, if you think about the University of Michigan, it's associated with two facilities. There's Michigan Medicine as well as the Ann Arbor VA Medical Center. And I'll just highlight a handful of things and insights that kind of were coming through. You know, if you can remember back, even though it does seem like a lifetime ago, to kind of late February, early March, you know, all these data were coming out from largely China as well as Europe on, you know, this new kind of novel coronavirus. And there were a lot of uncertainty around it, a lot of uncertainty about the infectious rate as well as the overall complication rates from it. And it's amazing that even 2 months down the line, we have more information, but we are still kind of unclear about a lot of core things around the virus, its infectivity, patterns of it, as well as like kind of, you know, really important things like death rates and complications that are associated with these infections. So if you think about this and you go back a couple of months ago, a lot of it was around trying to almost like kind of build the ship as you're sailing it. And so both institutions, Michigan Medicine and the Ann Arbor VA, took this very seriously and set up like command centers in both groups. The idea behind that was to try to do a number of things. One is to try to tackle the idea of what types of resources would be potentially required, what types of policies and procedures could be instituted to keep patients safe, our providers safe, our students safe. So all of this was kind of going on, and there was a lot of activity. You know, one example I'll give you is there was the establishment of the RICU, or the Respiratory Isolation Care Unit. That was actually set up in part of Mott Hospital, and it was a great kind of facility to set up so to isolate these patients from other patients to prevent kind of patient-to-patient transmission in these care facilities. And that was headed by Vineet Chopra, as well as a number of other leaders at Michigan Medicine. And, you know, to do this on the fly is no small thing. And I just have to say, you know, time and time again over the last couple of months, I've been so proud to be a part of kind of Michigan Medicine and the response it had. Not only did they have to figure out like kind of physical resources like that, but even kind of care resources like ventilators, dialysis units, again, expecting this surge to occur. And in the first few weeks, in early March, as we started to see an acceleration of cases, and there was a lot of concern about just even capacity overall. And there were plans even at some point about discussing a field hospital to be constructed nearby. So I just want to give you a flavor for all those things that were going on. I think whether it's due to some of the social distancing policies or, other potential factors, we have been able to kind of control this to a certain extent, at least at this point in time. The number of inpatient cases peaked around early April. Erkin will go over some of these details in a talk later. As of now, today, from a peak of about 225 inpatients, we're down to numbers in the low 40s, with over 500 patients now discharged from Michigan Medicine. Some of them have been discharged home, some of them have been discharged to other types of care facilities. But I think that's a really impressive number and something we should be proud of as well. I'll end with just a couple of things, just insights around this. For patients, as many of you are, I think this has been a confusing time. We've seen with the need to kind of care for this potential surge, a decrease in elective cases, a decrease in kind of even semi-urgent procedures. Michigan Medicine is trying to kind of reactivate and reopen, as are many other things. We never really closed, but I think what we're trying to do is understand how we can start care. But it's really accelerated care in a lot of ways too. I mean, many of our care providers now become comfortable with telemedicine and telehealth services. It's also changed the way we've thought about kind of family interaction within the facilities. I think one of the saddest things about COVID-19 is the requirement for isolation, and that's been challenging in the hospital setting. But I think that, again, our leadership, as well as just kind of the patients and community, have been really remarkable. And, I think everyone's been fairly thoughtful about how we can kind of proceed with, again, just the idea of protecting, patients, the providers, as well as kind of the community overall. So.
Thank you. That was very useful to set the background of what's been happening in the medical world. And I would like for us to hear more about some of the challenges that have been raised by COVID-19. And we know, of course, that there have been challenges, as Brahmajee mentioned, with respect to diagnosis and treatment, but there are also many other implications in health. So I would like to ask Larry if you could please give us an overview of some of the difficulties that were encountered in the medical field.
Okay, great. And I think I'm going to sort of build on some of the themes that Brahmajee was talking about. So it really is an incredible time. Once again, thank you. It's an honor to be here and part of this really great group of people doing this work here at Michigan Medicine, University of Michigan. When I think about this, I think about a perspective of sort of information and communication. What is it that people know, where they're getting their information, and how do they process that information? And thinking about that from the perspective of the general public, thinking about that perspective of patients and families and healthcare workers themselves, right? And I think that, boy, it's been a really incredibly fast-moving field in terms of the information, right? Some basic questions about what is coronavirus, what are the symptoms, how can I protect myself, what is social distancing, and what is the appropriate practice of social distancing? These are all questions I think none of us really had in our mind 3 or 4 months ago. And we've gone through, I think, many iterations of what the answers to those questions are, right? And so I think understanding and trying to address how do people receive and process information in this rapidly changing environment is really challenging, right? And I think what we're seeing, which is, I think, going to be a challenge as we go forward, is a diversity of beliefs and misbeliefs and a lot of uncertainty about what's really true and what isn't. Some of that is unavoidable because the information is evolving. Some of it, I'll just say maybe is avoidable and probably not say too much more about that right now in terms of communication. Right. From the perspective of patients, I think, as Brahmajee was mentioning, it's been sort of an evolving story. Who should be tested? Where can I go to get tested? What are the criteria for testing is important? What is it like to have coronavirus and what are the treatments and what can I expect? So there's a lot of questions that have been evolving just around the direct aspects of care, but then also the indirect aspects of care, because it really changed the way healthcare is delivered. We do a lot of work in the cancer center, and it's been a real issue there where a lot of much of the routine care had to be rescheduled or changed related to the surge in COVID patients coming into the health system and the desire to keep our cancer patients safe during the COVID crisis, particularly during the peak of the COVID crisis, right? And so those are things that were important to do, but also were difficult and challenging to carry out, right? So expanding a little bit out from patients themselves as you think about sort of families and caregivers, because I think that it's been a real experience. How do we sort of, it's not just individuals dealing with coronavirus, but it's households that are dealing with coronavirus, right? So what do we do and how do we act as a household? How do we keep a household safe? If you have a family member that might be ill or might be high risk, how does that change how your household should act, right? Expanding sort of a little bit out from there, thinking about sort of the healthcare teams that I think, like Brahmajee, I'm incredibly proud of the job so many people have done, sort of leading Michigan medicine's response, but it's also important to remember that providers are people too, right? I think it's been really difficult for providers to be trying to initially take care of so many patients with COVID without having effective treatments, right? So this is a relatively new experience. And thankfully, there are sort of effective treatments that are being found and are in the pipeline. But that itself took a great toll on the sort of emotional toll, I think, on healthcare workers as well, in addition to concerns just about being safe, right? And so I think those are the complex sort of nature of all of these issues. And I think it's only going to get more complex going forward, right? So there's general levels of uncertainty, worry, stress, anxiety, right? Whereas social distancing was very important, there's also the social isolation that's come along with that. How do we understand that? How do we deal with that? And of course, there are sort of the economic and financial concerns that have been sort of the result of some of the stay-at-home policies that were required to contain the virus and prevent many more thousands of excess deaths, but also have hardships and burdens associated with them as well. So there's no simple answer, and the story continues to evolve. And being able to track and process all of that information to make individual decisions, I think, is going to be a great challenge. And so that's something that, working with you and the others, hopefully we can help with that over time. And the public library.
Definitely. And thanks, Larry. A lot of these conversations have started some of the brainstorming that I mentioned earlier we had at the beginning. So as you heard, Michigan medicine has been right at work even before the pandemic has started. And in the AI lab, we started conversations with Larry and Brahmajee and Erkin and many others on what we could do to help. And tonight, we would highlight 5 projects that have emerged from these conversations. There are several others that are in the works or exploration mode. And I would like to start with the MCures project. So I'll invite Erkin, Otles, and Brahmajee Nallamothu, if you want to share with us the work that you've been doing on MCures.
Excellent, thank you. Let's see if I can kick this off. All right. So I can't see my own screen, so you guys will let me know if you can't see my screen, but I assume I'm sharing it with you. I'd like to thank the Public Library for having us, and I'm just going to talk briefly about our project entitled MCures, which is short for the Michigan COVID-19 Utilization and Risk Evaluation System. And I'm Erkin. I'm an MD PhD student here at the University of Michigan.
Erkin, this is Brahmajee. I don't think we can see your screen.
Oh, you can't? Let's try again.
There we go.
Yes.
Excellent. Are we good?
Yes, onward.
All right. So that was, luckily all you missed was the title slide, so we can skip right past that. And so Brahmajee and Larry did a phenomenal job of sort of laying the story that I think we're all very familiar with in terms of our own personal lives, but thinking about sort of what happened in the last couple of months from the perspective of Michigan medicine and looking really at what's going on in the hospital. Here's a graph that Brahmajee had referred to, which is the number of patients hospitalized at the Michigan Medicine University Hospital every day. And so you can see the trend where we had our growth to hit about 200 patients. And then luckily right now, we're really sort of on the downtrend, and hopefully we can maintain that. But looking back to the early days, we see when we look back to end of March, we saw something that was a little concerning, right? The initial counts looked like they were we were going to potentially have tons and tons of patients coming in very quickly to the hospital, and with a disease that we really didn't totally understand, right? It was very novel for us, and it was novel for everyone in the world. And so there were, sorry, Siri for some reason is bothering me. Just a moment. Apologies about that. Can you guys see my screen okay?
Perfect.
Excellent. So we had a lot of tough questions facing us in terms of the society, right? If you looked back to the New York Times and even local newspapers, all kinds of questions were coming up, looking at the trajectory of number of patients and sort of saying, well, based on the trajectories and the number of beds that we have, the number of ventilators and ICUs, are we going to be able to meet the demand? University of Michigan was looking at spinning up a field hospital, and all kinds of questions were sort of floating through our heads at the end of March. And specifically at the University of Michigan, we had, more specific questions, right? We have the same macro questions that was going through everyone's minds in society, but we also had, technical related questions, right? Like, well, if we open a field hospital, who can go to the field hospital? Like, who's going to be healthy enough, relatively speaking, to go to a place that has, less support than the main hospital? Will we have enough ventilators? Will we need more ICU beds? Will we be able to closely monitor all these patients, given that, we may need to bring in physicians that don't necessarily take care of patients in the hospital routinely? So there was a lot of tough questions that we were facing. And we started talking between Michigan Medicine and the Michigan AI Laboratory, and really trying to narrow in, well, what's the sort of core of all these questions? And really at sort of the center intersection of many of these questions was, is there a way to find the highest risk COVID-19 patients? Because if you can figure out who's highest risk and who's potentially at most danger of experiencing a bad outcome, well, then we can potentially intervene earlier and do something about it. So we wanted to help build this early warning system to help physicians. And essentially, we'd like to be able to monitor the risk of adverse outcomes over time. And adverse outcomes we've defined sort of looking at the most critical things that can happen to a patient in the hospital. So this is the need for additional respiratory support. Some of you may know this as mechanical ventilation. We also have other things called heated high flow, just another delivery mechanism for oxygen to your lungs. We also have certain meds that we use to help support your cardiovascular system. And then there's also, the potentially one of the worst outcomes you could experience as a patient, which is death. And we want to be able to predict who may have these outcomes before they happen so we could intervene on them. And we want to be able to do this repeatedly over time. So we're sort of setting out to build a system that can give us a score for every patient in the hospital every 4 hours, utilizing data that's already being collected in the electronic health record. And so the system that we've been building is built entirely with electronic health record data. It combines vitals, which are routinely assessed heart rates, blood pressures, oxygenation status, temperature, along with all the medications that you receive in the hospital, laboratory results, and then other documentation that may be charted by nurses or physicians. All of this goes into the EHR. We have a model that uses this data, is able to compute the risks automatically. And we're working now to have this model and be able to deploy this information once we get it from the EHR, push it back through the EHR or electronic health record to the physician so that they are able to flag potentially who of all the patients that are hospitalized and that they're taking care of, who's the highest risk? Who should they be thinking about in terms of, this person may need to go on a ventilator in a couple hours. What can we do to either get ready for that or to help prevent that deterioration event? So the model that we have is not built to tell us who should and should not go onto a ventilator or another resource. It really is to help sort of be a guardian, to help physicians think about, this patient may experience this event in the future and help to guide physician and clinician decision-making. So thinking about, that, well, what does that mean for the future of this model and what will we do with it at, Michigan Medicine? Well, going back to our curve, there's a couple different ways that this could play out, and I'm not going to, speculate and put my chips down on one particular scenario, but, there's potentially many ways that this could play out. And I think through our collaboration, it's been clear that MCures could be used in many different ways. So if we were to experience a second wave, right, this is sort of what MCures was initially designed for, was to help with the first wave, but it could help to respond to a second, sudden increase in hospitalized COVID patients and be able to help, manage all these patients and think about sort of what's going on and help alleviate some of the burden on physicians in terms of monitoring the patient population that's admitted. But then there's also what happens if, the COVID number of COVID patients plateaus, which we've been experiencing, and thankfully it stays that way. Well, we could still use it to take care of the admitted COVID patients. And even, let's say, if there was a magic wand and COVID disappeared tomorrow, which would be amazing, we could easily adapt the MCures model to be used for just general patients in the hospital. We've done some things that make it sort of specific for the COVID-19 patient population, but it's very easy to take this framework and extend it to all patients that are in the hospital. So in summary, MCures allows us to find the sickest patients that are in the hospital with COVID-19. And I'd love to, answer some of your questions once we get through everyone's talks, but it'd be remiss without throwing up a slide with the team. So myself and Brahmajee and many others helped to contribute to this work. And I'd just like to note that there are many people, both from the AI engineering side of Michigan, as well as the hospital, working on this. And it's been a real pleasure working with everyone on this challenging problem.
Thank you. This is fantastic. And I've been very impressed since the very beginning of this project and how quickly it's been developing and applied. So it's just incredible on how rapidly this team has been moving. And I would like to invite next Nikola Banovic to talk about another major change that we've been all going through, which is social distancing and how different behaviors would affect social distancing. So Nikola.
Thank you, Rada. It's really a pleasure to be here. So yes, we've all heard quite a bit about flattening the curve, and we just saw actually in Erkin's slides some curves and what's the actual importance of minimizing the growth. Also, what we've heard a lot about are the different policies that perhaps help us flatten that curve. So one of the policies is the social distancing. But what we don't know is how effective these policies are. We don't know how to debug these policies, so to speak. So to use an example that Larry gave earlier, we may have a family where there is a family member who is infected with COVID-19. How should this family deal with this issue? And perhaps they might hear suggestions like the infected family member should use the other bathroom, But that also brings up questions about what does this mean for different people who don't just have another bathroom lying around. So what's been really interesting for us in this project is to try and understand the effects of these different policies across different socioeconomic brackets for different people. And the way that we've been approaching this problem is through computational modeling. Now, another thing that you've probably seen quite a bit in the media are these different models that help us sort of understand the transmission rates, help us understand how different policies affect those transmission rates. And those are usually the little random dots moving around the screen. And as much as they are effective in painting a picture of what these policies can do, they do not necessarily put people into realistic situations and do not necessarily model the behaviors in a realistic way. So what we were set out to do is to create models that allow us to test these policies before we put them in place, before we can actually even empirically test them in the real world with realistic situations for realistic people. So what I would like to show you is just a very quick demo of some of the simulations that we've done and visualizations for those simulations, and perhaps help explain this project through this example. So hopefully you're all able to see my screen now. All right, excellent. So let's, for a moment, suppose that we have a family who has a family member that has been infected with COVID-19. So here what we are seeing is a family of 5 with one young adult being infected with COVID-19, living in a 1-bedroom apartment with 1 bathroom. And now you might think that this is not necessarily a realistic example, except that this is directly pulled from US Census data. So what we are doing in this particular case is we're taking data from real people or simulations of synthetic families, but realistic families, and then putting them through different kinds of situations in their living spaces. So in this particular case, what we can do is we can see how this family behaves without taking into consideration any kind of social distancing policy. So in this particular case, this could be a family that is just going about their day, perhaps taking a breakfast all together in their dining area. And as they're moving about, they're getting into close proximity to one another. Now we'll speed it up just a little bit so that we don't spend a considerable amount of time just looking at them around their breakfast table. But one of the things that you will start noticing is that in our models, we are also looking at how the people who are infected infect other surfaces, perhaps by touching them, perhaps by coughing, sneezing, and so on. And one of the things that you can see here is that we are already finding some family members that are getting in contact with these surfaces. Now, as much as you can see a family member who is red here, who's infected, we also see family members who have gotten in touch with the virus. They have not been infected yet, but they are in contact. And now what we can do is we can continue this simulation and let these family members go about their day. And one other thing that we can notice is that there continue to be surfaces that are still infected by or that have been in touch with the virus, but also that there are people who have been exposed to it. And as they go about their day, of course, at certain times we can speed up this simulation even further. Not only are there more surfaces being infected, and not only are more people being exposed, also what is happening is that they themselves might get infected. And I will just speed this up a little bit more. And as we see more people being infected in the family itself, there's of course more chance of exposure to other family members. Now, what we can do as well is we can look at another situation with the same family, where we can look at what happens, or we can simulate what happens if they are actually following some of the social distancing. Okay. So are you able to see my screen again? Excellent. So in this particular case, we have the same family, only now we're going to have a young adult who is social distancing away from the other family members. Now, they're going about their day in a very similar fashion, like they did before, except the young adult is being self-isolated in the room. Now, again, I'm going to speed up a little bit and see what happens with the infection, and also the family members that are moving about their day. Now, one of the interesting things here, perhaps, is that in the models that we've seen up until now, we have these simulations of social distancing that do not necessarily take into account the needs of people. Now, in this particular case, we have a young adult self-distancing in the bedroom, but this is also a real person who sometimes needs to use the bathroom. So our models also take into account these kinds of needs that people have and the kinds of risks that that kind of behavior puts on other family members. Now, of course, I'm not going to continue much further with this simulation. Hopefully, it's just something that has given you an idea of what these models can do and how they can help us try to compare the different transmission rates based on different policies that family members take while at their homes. Now, one of the things that I just want to point out here is that you've seen one particular example, one visualization of a simulated family. But one of the things that these kinds of models allow us to do is to run many, many simulations, not just of this one family, but also all the other families that we have in our data sets in these large US Census data sets. What that allows us to do then is to actually probabilistically estimate these different curves that we can get from different policies, and then that allows us to compare the different policies and then better understand which ones are more or less effective. Now, of course, we are seeing some of the flattening of the current curves that we're seeing right now, but one of the things that this kind of tool can help us with is also understand how we can fight potentially the second wave of COVID-19, or perhaps deal with other similar situations that we may experience in the future.
Thank you. And I know this will continue to be highly relevant. In fact, I've been hearing that a lot of the infections are actually happening within households, and we'll see for a while that social distancing will be with us, so it'll be very relevant. So I will want now to move next to Larry to share with us the Making Meaning project that he's been working on, addressing support for cancer people within this outbreak. Larry?
Great. Can people hear me okay?
Yes.
All right. I'm going to try to share my screen, and I'm going to try to make it actually the slideshow. So hopefully that's working for people. Nod if or shake your head. So I just want to introduce this really quickly. This is a project that actually Rada helps with the connections. The issue we're trying to address here is that I think all of us have sort of experienced that COVID and the coronavirus crisis has been overwhelming. At the same time, sometimes, you know, during all of this time, everything's going, some people have found out they've had cancer or been undergoing cancer treatment, which is also overwhelming. So there's a subset of people, and this is related to our work in the Cancer Center, but that are sort of dealing with two overwhelming crises. And how do you help somebody in a situation like that? And there's no easy answer, of course. But I was introduced recently to the work of Professor James Pennebaker at UT Austin, who does a work on something called expressive writing. And this work actually has been going on for over 20 years. And it's the notion that all of us as people have the need to make meaning of our world, right? And if we can make meaning of our world and start to understand what's going on, that we can be more effective in handling, coping, and dealing with whatever challenges we might be facing. I don't know about everybody else out there, but myself, sometimes I've been so busy just trying to deal and handle and cope with what's going on. I haven't had a chance to start to think about what does this all mean to me? What does this all mean to my family? And because of that, that generates inside a person's mind and body a lot of extra worry, stress, anxiety, and burden, which can have a whole host of health effects in terms of your heart, your mental state, even the function of your immune system, right? And so this notion of expressive writing is actually a fairly simple one, that if you give people a writing prompt and ask them to write for 3 to 5 minutes, and do that on a couple occasions, that very process of telling a story to yourself about what's going on in your life can be tremendously important in terms of making meaning of what's going on, right? And so we worked with Dr. Pennybaker at UT Austin. Rada's been helping with us, Charlie's been helping with us to build an expressive writing site for cancer patients and caregivers of cancer patients to be able to come in and essentially write about what are your thoughts and feelings about your life right now, or what are your thoughts and feelings about coronavirus and cancer, or something positive that might be going on. Because I think that's also part of the story as well. I think many of us are looking forward to getting back to something that we haven't been able to do. For some people, it's an amazing trip. For other people, it's a very simple thing of meeting up with their neighbors, families, and friends, right? And so being able to recognize that. And so we're building a site that encourages people to do some of this writing. We do a little bit of an assessment as they come in, as that they leave. And then the connection to AI, or artificial intelligence, is we're using natural language processing techniques, once again, working with Dr. Pennybaker in this case, to process a person's writing and give them feedback in terms of how meaningful was the exercise, how much are they engaging in self-reflection, and what is the emotional tone. And the feedback is not meant to be therapy, because this isn't therapy, but just hopefully to promote some insight and processing for people as they, as we call it, make meaning for themselves of what's going on. And so this is definitely a work in process. We're in the process of rolling this out to our cancer patient population, and hopefully to other cancer patients in other clinics around the state and maybe the country. And I think that, it's founded on very solid science in terms of the benefit to individuals, but I think there's also new ways to provide the engagement and feedback. And I think Charlie's going to talk about some of that. So I just wanted to introduce that idea. And I'm going to stop sharing my screen.
All right, thank you. This is great. And as you heard, this is addressing primarily people who have been diagnosed with cancer, who are dealing with major challenges in their lives. Aside from cancer, there is now also COVID-19. And one idea that we'll hear next is how we can apply this support for anxiety during COVID-19 to general population. And Charlie, do you want to share with us?
Yeah, thank you. So I'm going to share my screen now. Here we go. So we've been working on a project called Expressive Interviewing, and this is related to what Larry was just talking about. We have a number of people on our team, computer scientists, psychologists, health professionals, and doctors from the University of Michigan and Texas at Austin. And there's some of us have been introduced already. Larry's here, but there's more information about us on our website, expressiveinterviewing.org. But what we've built here is a tool, a writing tool to facilitate introspection. And I have a little demo here, and it's showing CP, the computer program that you can converse with. It asks you how you want to be referred to, and then it starts with this expressive writing prompt, but it's also more interactive, and it's asking people how the COVID-19 pandemic is affecting them. And so we have two goals here. The first is to learn more about how people are responding to COVID-19. So this is useful information for us to gather from people, but also, as Larry described, this process of expressive writing can have many benefits to users. And in some of our preliminary sessions with people who've tried out the system, they have reported lower stress levels after the interaction. So we asked them a couple questions before and after they had this conversation, and one of those is related to their stress level. So we have these methods from expressive writing. This writing exercise to put your thoughts and emotions into words that has benefits for physical and mental health. And we're also bringing into it some work on motivational interviewing, which is a counseling style for eliciting behavior change and was originally used for things like helping people to quit smoking or drinking, or with to lose weight, but is also being used more for more mental health applications. And one of the ways that this is done is through reflective listening that's showing empathy to the client. And so this is work again with Jamie Pennebaker, who introduced expressive writing, and with Professor Ken Resnikow, who is a world expert in motivational interviewing. And so our system at the moment is trying to be human-like to make the user comfortable. And so we see this like simulated typing here to act more human. And then depending on what you say, it comes up with different prompts to continue to engage the user and have them continue to write more. So here I wrote that the pandemic is making me worried about getting sick or getting other people sick. And then you see this response where it's talking about health and it's asking me more about health. So it recognizes topics and it also recognizes emotions. So here I've said that there's a lot of sad things happening, a lot of other depressing things around the country. And it gives me this response that's asking more about my emotions and what's going on. And another thing you'll notice is it doesn't explicitly say, it sounds like you're sad, which would be a more reflective type of response that you might give in a motivational interviewing session. But a tricky thing that we're trying to balance is how to reflect back to the user what the system understands without misunderstanding the user, making them feel misunderstood. So it's more reflective if we can be more specific, but we don't want to say something wrong. And it's the AI doesn't completely understand the user. So that's something that we're trying to balance and still give prompts that are helpful for people to respond to and write about. But then after that interaction, they get this visual summary, a breakdown of the topics that they talked about, the emotions, their affect, are they more positive or negative about the things they're talking about, and their pronoun usage. So they're talking more about problems related to themselves and how it's affecting them or how it's affecting people.
Do you want to
they know.
advance to the next slide? I think we are seeing that.
Are you seeing the visual summary?
No. Maybe you can try again with share screen.
Does that work? Can you see visual summary?
I'm not seeing anything now.
That is strange. It says I'm sharing my screen. Still can't see it?
It just says to us that you've started sharing your screen, but it doesn't show anything. I don't know what's going on.
Okay, that's weird, but I can talk through the rest of this. So we give them some feedback about their emotional tone, how meaningful and self-reflective they were in the exercise, which is similar to the website that Larry showed. And we also show them the topics they discussed the most and the least. And then based on those, we give them references to other resources that they might find helpful. And we have a few directions that we're going in with this work. One of them is to work more on making the computer program more empathetic, which is difficult. And I have this example sentence where the system says, "I hear you, I'd like to ask you another question." And if you're talking about something that's more of a minor inconvenience that might sound more appropriate, the system is acknowledging what you said and then also saying that they want to ask you something else. But if you're talking about something more serious, like the death of someone you know, then it's just saying, "I hear you," and asking another question can sound dismissive. So
I share my screen. So is this the right?
That's the visual summary. I skipped to the ongoing work.
Okay.
So working on making this more empathetic, and can you go to the ongoing work slide?
I think I'm there.
I see visual summary still. I don't know what everyone else sees. Well, we want to do a more longitudinal analysis. So right now, you can go to the website and immediately start having this interaction. But we want to add user accounts so we can have interactions that build more off of how people have responded over time. And we want to add more prompts, some that are more specific to groups like healthcare workers and cancer patients, and some that are more general, because some of the feedback we've gotten is that people just want to keep talking to the system and talk about all sorts of different things, which is excellent. And one last thing is building rapport. So there are differences in individuals of what makes them feel comfortable in a conversation. And so we want to explore different personalities for the system and how it appears. Do we want it to be acting more like a human or more like a computer, where you're just more like a diary where you're writing how you feel about different things. And so there's some opportunities for personalization there. And so the website's online now. It's expressiveinterviewing.org. And we'd really appreciate it if you tried it out and gave us some feedback.
All right. Thank you.
Thanks.
And we have one more presentation. And before we do that, since we are moving now to the question answer time of the webinar, so please use the Q&A button at the bottom. I see there are questions there already, so please write your questions there and we'll try to get to them after the next presentation, which is about depression during COVID-19, and Laura Biester will share with us about that. You are muted.
Yes, thank you. All right. I'm going to be talking about understanding the effects of COVID-19 on mental health. And this is work with Katie, Jana, Emily, and Rada, as well as myself. So we want to think about what different effects COVID-19 may have on mental health. And we expect impacts from at least 3 areas, which have already kind of been brought up. The illness itself, the isolation from social distancing and the lockdowns, and then the economic downturn and people losing their jobs. So what do we know so far? We are not the first people to consider this as a problem. So there's been quite a few papers from psychiatrists saying that we need to focus on the psychological effects that are coming, especially from these lockdowns and from the illness itself. So they're anticipating increased stress among the general population and then also PTSD among medical workers. But an early result from a paper that was published in kind of the end of March showed that when the stay-at-home orders went into effect, actually Google search queries for mental health related terms kind of leveled off. So you'll see here that we have this escalation phase. This is like kind of a few days before the stay-at-home order. And then this interruption phase, kind of when the stay-at-home order had been announced. We see a big increase here during that phase, but then once the stay-at-home order was in effect, we actually see that these queries leveled off. So how have people been feeling? There was a paper that kind of just asked people to write about how they felt and their worries during COVID-19, and the very common emotion that was expressed was anxiety. And this was similar with data that was found from city subreddits, like for example, the Seattle subreddit, where we see a huge increase in words that are related to anxiety, especially as we see like the first US death coming in February 29th. And we're particularly going to be looking at social media. Social media has been used in prior work to study mental health, looking at things like predicting the presence of a mental disorder, looking at changes in symptoms or a shift towards suicide ideation in individuals, and even looking at the effects of psychiatric medication. So one of the subreddits that we're looking at is the depression subreddit, but there's quite a few different mental health subreddits that we're considering. And we want to look at the effects that COVID-19 is having on people who presumably have some mental health challenges because of their posting behavior on these subreddits. So first, we're looking at the degree of activity. So we want to see what the posting frequency is of existing users in these subreddits. And so this is for users who have been active between September and April consistently in three different time periods. And it's the percentage of posts that they make in each month. And we actually see that we don't see like some kind of spike in posts coming in March and April this year. It's fairly consistent across the other years. And then we look at the number of new users. We expect that maybe if there's an increase in mental health problems, there will be a spike in new users in these subreddits, or the percentage of users who have never posted before. And we actually find that across 4 different subreddits, the percentage of users who have not posted before and are posting in March and April is very high, but it's not larger than it has been in prior years. And we do want to see if these effects are consistent across different subreddits. Here we see that they are for the number of new users. We actually did see that in one particular subreddit for social anxiety, that there was a large decrease in new users once the stay-at-home orders went into effect. We also look at the effects on the content of posts and what people are talking about to understand the specific concerns that people have related to mental health. So we look at the changes in percentage of words from different psycholinguistic categories. Here we see that there's a really big increase in anger-related words and an increase in words that kind of fall into the we category, which would represent like togetherness or maybe closeness with the community. And so these are kind of opposite effects, but actually something that I thought was interesting is that there's similar effects to what we see around the holidays when people are spending more time with their family. And then we also look at changes in percentage of posts from commonly discussed mental health related topics that we extract from the subreddits. So the first topic that I want to show is related to work and money. And we actually see a decrease in discussion about this, which is interesting because an effect that we expected to see was related to the economic downturn. And it seems like, at least so far, in March and April, that hasn't affected people in the mental health subreddit to the extent where they're going to be talking about it more. And we also see a large decrease in people talking about kind of the medical side of depression and things like medication. We want to look also at how this compares to the general population. So earlier I showed this graph of the percentage of anxiety words on city subreddits. And we actually see that on the depression subreddit, while it's more unclear overall what the pattern is, there hasn't really been a clear increase the way that there has been on these city subreddits. So it may be that there's some relief, by like having something else to be worried about almost. So some additional questions that we want to look at are how the patterns of social interaction have changed and what different kinds of support people are getting from these subreddits. What specific factors influence the likelihood that someone may increase their activity in the mental health subreddits during COVID-19, and especially how their interaction with subreddits like the coronavirus subreddit may affect their mental health. And then finally, how specific groups of people have been impacted, including healthcare workers. And I think I can stop sharing my screen and get to the Q&A.
All right, thank you. In a way, I almost take
Perfect timing. Did Rada freeze?
Yeah.
It appears
Okay.
to have happened.
very
So-
consistent information that's not really the case. So we have several questions, and I will encourage people to ask questions in the Q&A portion of Zoom. There is one question which asks whether we could use AI to predict when will COVID-19 end, which is a very good question. So I will ask Larry and maybe Nikola if they can join this question. Larry?
Sure. So I can start the answer, but I think it really falls into sort of Nikola's wheelhouse. I think one interesting thing to think about is if you look at how COVID has played out in different countries around the world, it's had very different paths in terms of the number of cases, trajectory, and the impact. There are some countries that have been able to almost eliminate COVID, and there's I think there's a lot of work to be done to sort of model and understand why it's played out differently in different places. And I think that information can then be sort of synthesized to start to predict, what the different paths might be here in the US or in other countries around the world. And I think that ties very much into Nikola, some of what you were showing. So I'm going to turn it over to you to see if you want to add more insight into that answer.
For sure. So a short answer to the question is yes, they can. Can they do it accurately? Probably not. There has been a lot of interesting discussion about this. Also, Nate Silver from 538 has also shown a very interesting piece on why different models disagree and why it's so challenging to model such a complex system, such as what we are facing here today. But apart from just what the models can do, it also depends on what people will or will not do, depending on the kinds of policies that we put in place. And we already see that the question of some of these policies has been very polarizing. The other question here is, are we going to stay on the same path, or would there be some unforeseen events that will perhaps bring the next wave that our models will not be able to foresee? Will there be differences in how people perceive the flattening of the curve currently, and then start behaving perhaps in ways that will change that? All of these questions are very difficult to capture in some of the models. What we can do is we can give a lot of sort of predictions, perhaps even estimate the confidence of those predictions, and then using those predictions to try to inform our decisions in the future. But can we tell you an exact date? Unfortunately not.
Thank you. I see there is another question on what do we think we are learning during this pandemic that will help us develop methods that will prevent future outbreak from escalating to this point. So Erkin, do you want to try to answer that?
Yeah, I think this is a really great question, because sort of when we're in the thick of it, we were sort of thinking about how we get out of it. But really the greatest learning that we can do is sort of figure out how we don't get into the situation again. And I think a lot of what we've seen here is actually going to be very useful for that, because if we think about, well, even if we do get another COVID-19 like pandemic, or even if it's not a pandemic, if it's some type of large mass casualty event, or not an infectious disease outbreak, but we have some other type of widely pervasive disease. These are all tools that could be adapted to work in the new problem area. So I think, one, it sort of helps us overcome potentially, a pandemic or something else that maybe arises again, and we can get over it quickly. But then there's also the ability for us to sort of try to prevent it, right? So we can think about how we are developing our MCures model. If we had an MCures-like model that was, looking for potential outbreaks, or we had other models that are looking for outbreaks in hospitals, and then we could use that to more quickly respond to an outbreak and prevent it from really getting beyond a single hospital or a single city and sort of moving more quickly. So there's certain things regarding, infrastructure, and we're talking about like data infrastructure. So being able to get data from hospitals, being able to do analysis, sharing information between different, organizations, different hospitals, between engineers and also doctors, right? All of this, if we build that out for this, that helps us move faster and prevent the issue from potentially happening in the future. And then there's a whole bunch of phenomenal sort of softer stuff that's being done as well, right? Just the connections that are being strengthened by working between engineers and physicians. I feel like it puts us in a better place so that there's trust in the future when, a problem does arise. A physician could potentially say, an infectious disease doctor could say to an engineering colleague that they've worked with before, hey, we've been seeing this weird outbreak before. Like, I don't think it's like, all the other things that I usually deal with. Could you maybe help me with it? Could you help me dig into the data, right? These are things that in medicine, we traditionally don't have really good, we have great collegial relationships inside of medicine, but I feel like that's something that we are developing sort of with this, and I see a great potential in the future.
Thank you. And Laura, did you want to add something?
Yeah, I think that getting an understanding of maybe how people are reacting or people's reluctance to different measures that are put into place could help us to kind of inform what measures we would want to take in the future if something like this was to occur, or something where we might have similar reactions, like having a lockdown. But I think that could inform the policy and understand like what people are willing to do and what is going to be okay for people for their future, because I think there has been a lot of reluctance to social distancing. And I think that it's good to understand what impact that's actually going to have on people. And obviously we don't want to, release everyone and cause like more death that way. But I think that understanding how it's affecting people will be useful in future reactions.
Okay, thank you. Anyone else? Charlie, did you want to say something? Maybe Larry?
Charlie, you go first if you have something to say.
Well, we're already thinking about other possible applications for this expressive interviewing system that we're building. So I think that the potential for technologies like this to help people reduce stress and improve their mental and physical health during stressful times like this could be really useful in future situations that are similar.
Thank you. Larry?
Yeah, so I think that one of the things that obviously I think a theme across all of these projects you've heard about this evening, and I think that's sort of broadly true about coronavirus and a lot of health issues, is it's really about information, communication, and that flow, right? And I think a huge thing related to either it's direct information about coronavirus, the health system's response, individual response, a family response. I think having trusted sources of information are really important. And I think when groups have looked at this, and we've looked at this, Sometimes there's a little bit less trust sort of towards higher centralized information sources, but there tends to be a lot of trust in your local information sources. And I think that sort of going forward, there's a huge, potentially really exciting role for local information sources like your public library in playing a role in helping to organize the community's response to issues like this. So, I mean, I think this has been great to have this opportunity. And I actually am looking forward to sort of follow-up conversations with our colleagues in the public library about different sort of novel ways we can partner to help both locally and maybe around the country and world that builds on sort of healthcare information and libraries to make a difference with the pandemic.
Thank you. And that's a great way to close this Friday Night AI with thanks to the Ann Arbor District Library for hosting us virtually. And also I would like to thank all the panelists for all their contributions, Aura Bunescu for really organizing everything behind the scenes and making this possible. And of course to all the attendees for being here and supporting all the work that's happening. And thank you for participating to everyone. And this has been broadcasted on YouTube, so you can share a recording of this if you choose so with people who weren't able to make it tonight. And with that, thank you.
Thank you.